see you. I see the screen, sorry.
Thank you. Sorry for that disturb of my devices was blocking me. So I'm Dr. Jibia. I'm from Yaounde Central Hospital, and I also have been studying Abidjan, Ivory Coast, and I'm also working there with my colleague and other colleague. We have decided after 13 years of experience to talk about our experience of complication on ventriculo-peritoneal shunting in a sub-saharan paediatric neurosurgery unit. So, first of all, to know is ventriculo-peritoneal shunting is a principal treatment of hydrocephalus. It is widely practiced worldwide. Complications are countless, mostly screened in, and they are mostly screened in children. Their management in sub-Saharan area face families with limited resources and despair. So it's just both a surgical and social challenge for us. Our study was to think about this new pediatric neurosurgery unit, to make a retrospective cross-sectional study of 13 years of experience. So from 2003 to 2015, we do operated 302 children, and we do collected 62 patients with 62 children who did have complication in those 13 years. And we do take about 19 complications. What was our result? So the annual incidence of complication was elevated to 1.58 per year. That is above 20 for all those 13 years. The average year of age of children was 2.8 years. It was mainly male with a sex ratio of 1.5.7. It was surely most infant than grade children, something of 70%. Most of our children was operated in above 1 or 2 hours for their initial surgery, and it was mainly done by young neurosurgeon, junior neurosurgeon. We do register 52.19 complications. It was mechanical complication, and there was also infectious complication of 38/90. This is a diagram to show you what was our mainly mechanical complication. They are all regrouped here. It was surely disconnection. We do register 9 on the mechanical complication. Also, 15% of dysfunction. We do register abdominal occlusion or supraocclusion, but there was no shunt fracture, but there was over drainage for 7 patients, catheter migration for, let's say, 6 patients, 11%. For infectious complication, it was mainly meningitis with 36%. We do register what we group as hyperthermia, because it was just an hyperthermia, but with no more, let's say, etiology, but we thought that it will be malaria also. There was ventriculitis for 2%, 2 or 3%. We do register also cerebral abscess and parietal abscess for 2 of our patients. The involvement was, let's say, favorable for 30%, 4% of our patients. We do register 16 patients who died, deceased, and we do register, let's say, complications of 5% after the second revise. Let's, sorry for people who will be, let's say, scared, but this is to show type of complication we do have in our context. So this is an extrusion of the shunt, the abdominal shunt in infant, something like 5 months old. This is an over drainage, as you can see, the fontanella, which is more decreased. And this is X-ray show a disconnection with a migration of the ventricle into the brain. So what can we say about it? Shunt complications occur in children, as Neta tell us, of about 50% on patients who have, it can be shunt for 2 years old. 30% of people or children can be shunt after 2 years old. It means that many children can make their first complication during after the first shunt. In our context, we do have mainly infants. We do have complications. We have registered some risk factors of hydrocephalus complication. There are 4 of them. Firstly, early post-shunting complication. That is, as the literature instructs us, when you have a complication after the first complication after the shunting, we are able to make other complication and other complication. The other risk factor is malformative hydrocephalus, mostly for obstructive one. It's a congenital hydrocephalus. Another risk factor is male gender. And some authors talk about the low socioeconomic status. Prematurity is another factor, another risk factor, mostly for infection ones, due to the fact that those children haven't completed the maturation of their white cells, so they are able to make some complication. We have also reduced risk factors for early surgical complication. First of all, it was for hydrocephalus complication, but this is for early surgical complication. We can have femoral etiology of hydrocephalus, the large cranial perimeter of the infant before his first surgery, and also a long post-operative hospital stay can be due to economic problem, to, let's say, we are not certified of cicatrization and so on and so forth. But the literature tells us that programmable valves, let's say programmable shunts, may reduce revision of shunting, or may reduce also drainage failure, let's this before 18 years old. That's the point we can talk about. In conclusion, we can say that ventriculo-peritoneal shunting in sub-Saharan area may have good long-term outcomes. Complications are globally comparable worldwide. The challenge, the surgical and social challenge can be controlled by an initial management of hydrocephalus in children, an early secondary management of shunting complication, and the ongoing training of surgeons. By this, I thank you for the kind attention.
Thank you, Dr. Alain, for the insightful presentation. Do we have any question for Dr. Alain Jibia?